So over the slides, I'll be covering up what the Ayushman Bharat Arogya Karnataka scheme is, what the online referral module is, and how the module has improved the status in Karnataka. Next slide, please. So, Arogya Karnataka is a scheme which has been started by the state of Karnataka with the aim of universal health coverage, where they were providing a fund of rupees 2 lakh people for all the BPL population, as well as 30% of the charges for the APL population. And at the same time, the government of Karnataka launched the Ayushman Bharat scheme, where they aim to provide rupees 5 lakh. So the state of Karnataka integrated the scheme, and it's now known as the Ayushman Bharat Arogya Karnataka scheme. So under this scheme, we have the State Health Agency SAST, which provides for all the claims. And through this integration, we are covering around 1,650 procedures, which includes 2A, that is the simple secondary procedures of 294 procedures, 251 complex secondary procedures, and 934 tertiary procedures, and 171 emergency care procedures. So every individual can avail these treatments based on the ABRK ID, which is being given to every individual based on their Aadhaar card or ration card. Identifying the real beneficiaries, we have two criteria in the scheme. One is the eligible patient and second is the general patient. A patient falls into the eligible category if the resident of Karnataka or has the eligible household card as per the NFS data, or is the BPL ration card holder, or has been enrolled into the existing Rashtriya Swasthya Bima Yojana, then he receives an amount of rupees 5 lakh per family, which is on a floater basis every year. Now, supposing he is a resident of Karnataka but not a BPL population, then he comes into the general category where he will be having an APL ration card and he covers around 30% of the government packages, which will come up to rupees 1.5 lakh per family per year. Next slide, please. So please click. So what happens during this, with the online referral module, what we have is, if a patient comes under any of the simple category, simple secondary procedures, which are 294 procedures, they will be performed in the government hospitals only, and he cannot be referred to any higher secondary hospitals, as all the government hospitals have such facilities. Now, supposing a patient requires any of the complex secondary procedures or the tertiary care procedures, then these procedures can be availed in the higher government hospitals or any empaneled private hospital, provided he receives the referral from the government hospital. And no referral will be given to the patient based on any particular hospital. We provide them a list of 50 hospitals, whichever are nearest to the hospital, where they can go and choose from their own side. So please press enter. In cases of emergency services, the patient is free to go to any of the government or the private empaneled hospitals without any referral, but the charges will be covered under the scheme. Next slide, please. So every patient receives an online referral format. This project is done in a partnership with the Department of Health and Family Welfare Services, the State Health Agency, which is known as the SAST, and the National Informatics Center from Karnataka. The main objective was this, to identify the hospitals which require the services. Secondly, to avoid any unwanted referrals, taki everybody can utilize the best of the government services which are available in the state, as well as to identify the gaps which are available in the government hospitals and improve them, as we have a capabilities module of which I will be discussing. Next slide, please. So what happens in the online referral is, supposing a patient has come to a government hospital and he requires any of the complex or the tertiary care procedures, they are given a referral format which contains a list of the 50 hospitals with the specialization that they require. There are 50 hospitals, we will give them the name as well as the contact details and the address, along with the distance from the current hospital that they are in. So out of the 50, the patient is free to choose any hospital that he wishes to go. How we're preventing any misuse of this referral format is, to generate a referral format, we have the biometric authentication of the nodal officer. I will be further explaining the role of the nodal officer. As well as the referral letter cannot be generated if the hospital has indicated the availability of the procedure based on the capabilities model. Next slide. So what happens is, every hospital has a capabilities module in which they give real-time data of what particular procedure or specialist is available for that particular day. So now, if a patient wants a referral, we have an operator in place who will register the ABRK ID and provide the patient a referral card, which ensures that the operator gives it to the patient itself. So we're avoiding any misuse of the referral. Second thing, this referral format will go to the referring doctor. He has to ensure that that particular process is not available in the existing hospital. Then he will enter the details of what is the procedure, what is the patient diagnostic, as well as whatever investigations and treatment has been done so far. So that when the patient has been referred to the further hospital, the doctor can access to whatever has been already done so that the line of treatment is not repeated or the patient avoids any excessive expenditure. After that, he will upload all these documents and it will be submitted to the nodal officer of that particular hospital. Now, the nodal officer will enroll into the capabilities module and ensure that that particular procedure is not available for that particular day. Only after that does he authorize the referral format. And then he will check for if there are any further pending cases for refer also. And then he ensures that the referral format is printed and given to the patient. Next slide, please. So when the patient receives the referral format, this is the sample referral format, which will include the ABRK ID, the patient name, as well as from where he's being referred to, what is the diagnosis, and the hospital even has to mention what is the reason that the particular procedure is not available for that particular day. And upon with that, if there are any additional issues or remarks related to the patient, they refer to that. So enter. So this is how it looks. And then since, next slide, please. Since it is in the state of Karnataka, we've made to ensure linguistic validity. So we provide the referral format in the form of Kannada as well as English so that it's patient friendly and everybody can access it. Next slide, please. So giving the last 3 months time period, if we go district-wise in the state of Karnataka, we have Belgavi, Bangalore Rural, and Mysuru district, which has been having the highest number of referrals based on their availability of services, as these hospitals were improvising lately. Next slide, please. We have this referral format, which is again divided based on the specialty. So if you look at the specialty, we see that urology is one specialty which has received the highest number of referrals of around 1,788, followed by neurosurgeon and medical oncology. Whereas if you look at the other departments, we can analyze that the government are strengthening in these particular departments and they're lacking in these particular departments, based on which we aim to improve the government hospitals. Next slide, please. So through this integration, so can you please continue to press enter? Yeah. So through this integration, what are the benefits? First thing, Karnataka is the first state to have such an online referral module, which prevents any others, which is different from any other state, so that it ensures that the patient receives the right care in the government hospital itself and is able to avail the best of the universal health coverage scheme. Second thing is, with the referral letter, we're ensuring linguistic validity as well as leaving the patient the choice of choosing his hospital. And we're even providing them a detailed information of which is the hospital, the details, and how they can contact them, so they do not have to go in search of anything during emergency. The next thing is, by this, we are understanding what are the gaps in the government hospital, as well as we aim to improvise them with various methods. With this, I would like to conclude. Thank you.
A very good presentation, and it was to the point also. Just one question I have in mind. Suppose a person is having emergency.
Yes,
he has no time to see online, that for online, this, that. So can he go straight away to the nearest hospital and
yes,
get the facilities?
Yeah, in cases of emergency, if you could refer to the previous slide, in cases of emergency, the patient can go to any government or empaneled private hospital and avail the services without any referral format. But the charges will be covered in the scheme. We have 171 emergency procedures.
What proof you will ask for? Whether a person is eligible or not. For example, if he's in general category, he will get only 30% or whatever.
So for that, the patient, we have 171 emergency procedures. So if he comes under any of those 171, then that is the first proof it was an emergency condition. Second thing, the patient, after the process is done, he will have to provide his APL or the BPL card based on which we will decide whether he belongs to the 5 lakh cash scheme or the 30%. And then the ABRK card ID, once he gives us that ID, sir, we will get all the details of which category he belongs to and all the details, because the ABRK card is linked to the Aadhaar card and the ration card. So all the authentication and verification is done previously and only then provided with registration.
Yeah, okay, fine. Because even this may take some time. No? If somebody is met with accident and all that, he can be immediately admitted and you start his treatment and then ask for this. Is it like that?
Yes, sir.
Good morning, sir. I would like to clarify. I am from SAST, Dr. Asif. Sir,
Please.
here actually, if it is any emergency procedure, the patient first goes to any of the empaneled hospitals. Here, the treating doctor will call one of the emergency numbers that we have. And we have a team which is like available for 24/7, sir. And the treating doctor will talk to our doctor and they will explain on a telephonic conversation whether what is the condition, what is the procedure they intend to do. And the permission will be given. They will first treat the patient, sir. After that, within 24 hours, they have to raise the pre-authorization. So that is the whole process, sir.
Okay. Thank you.
Thank you, sir.
Good.
Sir, I'm not able to hear you. I think you're on mute.
Do you have any feedback from beneficiaries, how they like this scheme?
Yes, so we have received feedbacks from the beneficiaries where they've been very thankful and helpful that, you know, it's become easier for them without any hassle during the times of emergency and treatment.
Okay. Thank you, please. Thank you.
Thank you, sir. Any other queries?
Thank you, please.
Thank you, sir. Karnataka. That is, we have the RBSK scheme, which we will which has been integrated with ABRK, for which I will be discussing the details further. So as mentioned earlier, I will just have a quick glance through the slide since it's done earlier. The Ayushman Bharat Arogya Karnataka scheme, as you know, is an integration scheme of the Ayushman Bharat and the Arogya Karnataka. And
this you have covered already. No
yes, sir. This is the same thing.
No need to repeat.
Okay, so coming to the next slide, which is the RBSK, which is Rashtra Bala Swasthya Karyakram. This was launched by the government of Karnataka under the NHM. And the main aim of this was to have early detection and management of the 4Ds, which are the defects, deficiencies, developmental delays, and diseases in children. And it also aimed at reducing the extent of disability by improving the quality as well as enabling the children to achieve their full potential. So during the scheme, what would happen is there would be one screening which is done yearly in schools and college children, and 2 times screening would have been done in the Anganwadis. And they have launched a Swasthya Kirna software, which is a mobile software where every child which has been screened along with the treatment and the referral details have been provided up on the software, which can be traced further. Next slide, please. So in RBSK, what happens is, supposing there's a newborn children, there are 2 types of screening which is done for them. First is the facility-based screening, and second, we have the community-based screening. In the facility-based screening, it is done in any of the public health institutions, and it is covered by the existing manpower itself. Supposing for the community screening, we have the ASHAs, which do the home visits for a newborn up till 6 weeks of age. Now, for 6 weeks to 6-year-old children, the screening is done in the Anganwadi centers, through which we have mobile health teams. I will discuss about the mobile health teams further. The mobile health teams are, we have around 430 mobile health teams, which do screenings in Anganwadis, government-aided schools for all the children. And for 6 to 18 years of children, we have screening in the government and government-aided school, which is again by the mobile health team. So the entire RBSK implementation happens from the mobile health team as well as the existing staff and the ASHAs at the facility level as the community level. Now with the integration of the RBSK with ABRK, what changes have happened is, see, in RBSK, they would do screening for children who are in schools or in the Anganwadis. But through the integration, ABRK improves the coverage by screening children who are even outside school. So we are reaching the unreached population also. And like I said, the 430 dedicated mobile health teams, which are a part of the RBSK, are integrated with ABRK. So now, apart from doing screening for the Anganwadi and the government-aided schools, they even reach children who are unreached through the APL and BPL population screening. Along with that, we have 18 dedicated district early intervention centers, which also do screening and identification for services at such centers. So the main purpose of this DEIC is to refer the children for the appropriate treatment. Now, in this RBSK would be providing the simple secondary care, but through the integration, ABRK is providing the secondary as well as tertiary care for the beneficiaries through an online referral system. RBSK covers around 100 procedures, out of which 57 procedures are now being signed in the MOU, which is a part of the integration. And out of these 57 procedures also, 8 procedures, which are the 2A procedures, that are the simple procedures, will be performed in the government hospitals only. And whichever are the 2B procedures can be performed in the public hospital or the private hospital. Why we've included 57 procedures is, as I told you earlier, ABRK has 1650 procedures. So out of those 1650 procedures, 57 procedures which refer to children have been signed in this MOU out of the 100 that the RBSK has. Now, to ensure that the patient has been referred rightly, we have a referral system. We have a referral form, which the individual has to fill online as well as offline. And then in whichever hospital he is, the attending medical officer will sign it along with as well as he will provide a discharge summary. Now, with this referral format and the discharge summary, the individual can go to any of the government hospital or the district hospital or to any of the DICs and approve the referral services. But supposing he has to go to any of the private empaneled hospitals, only then a birth certificate is mandatory, which will be provided by the public health institution itself before referral to the private institution. Otherwise, without the birth certificate also, an individual only with the referral format can avail the service. Next slide, please. So what are the benefits to this integration is, first thing is the SAST will ensure the verification as well as registration of these referral formats. And all the claims and the cash has been provided within 21 days. So there's no delay in the cashless service provided to the beneficiaries. Otherwise, ABRK was providing services for IPD only, but through this integration, ABRK provides cashless services for children based on OPD investigations and consultations also. And as I told you, there's a better patient coverage as we're reaching the children who are unreached out of schools also. And due to this screening, there has been an improved physical as well as mental health of children and improved attendance of children in the school. And second thing, if any patient is being referred through this system, then the child even receives the travel allowances, which are based on their traveling. Next slide, please. So if we look at the district-wise procedures, this integration started in June 2018. So from June 2018 to May 2022, if you see, based on the integration, we have Bellary, Hassan, and Shimoga district, which have used this scheme, amounting to 20,000 change each of them. Next slide, please. And if we go for specialty-wise, we have general medicine and two other. Next slide, please. General medicine and pediatric surgeries and simple secondary general procedures, which have been done under this integration. All the other specializations have also been done, but these three are the major specializations which have a higher coverage, which come up to around 2 lakhs per specialization. Next slide, please. So through this integration, we're ensuring, first thing, there is a cashless service provided to the children. And second thing, since there's a cashless service provided to the children, there is an improved interest of the parents also to ensure that the child has a full life and they're not ignoring services which are improving the child care. Second thing, this is a very simple scheme which can easily be integrated and replicated in all the other states of the country, as RBSK is a scheme which has been running across the state, as well as ABRK is a scheme which has been running across the states. And since all the data is available in the referral system, there is no kind of duplication. So there's no patient who's, availing cash from here as well as any other scheme. So there's no duplication of data, as well as there's data transparency. Thank you, sir. With this, I would like to conclude. Any questions?
Good, madam. Just one small question. or rather clarification.
Sir, you're muted. I'm sorry, I can't hear you.
Hello.
Yes.
Am I on mute? No.
Yeah, now you're on.
See, you said unreached children. No?
Yeah.
So what are those? Are they school dropouts, or are they people from below BPL families and you are not able to trace them and something like that?
Yes, sir. Those children who are like RBSK would do screening only in schools, but with the integration, we have screening for children who are outside schools, like not
school,
in schools.
Anganwadi,
Yeah,
okay.
kids who are not a part of any school or the BPL population or living in lower slum areas, all such children are also covered through this scheme. Because
how
we
do you
conduct,
do that?
We have these mobile health teams, sir, 430 mobile health teams, so they do screening over there also.
Your people go there?
Direct, yes, sir. Direct walk-ins also to the hospitals are encouraged, as well as the mobile health teams go to particular localities and conduct screening.
So is it successful that way? You are able to trace them and really help them?
Yes, sir. We've been able to trace them and help them that the data is reflecting.
Okay. Now my last, you made 2 presentations. Okay.
Yes.
So I just wanted to suggest you that you should get some independent third-party assessment of your procedure.
Okay.
Are you getting me?
Okay.
Third-party assessment of your procedure, as this is how you are doing, this is what you have achieved. So they may suggest something good. They may interact with the people. They can bring back
So
some good suggestions.
we have the state health agency known as the SAST, which does this verification.
No, that is a different thing. See, an independent agency like those who conduct special studies, they will tell you that this is, I mean, it can be 100% you are fine. They may say there is no further addition required, or they may come out with certain more suggestions, keeping especially view the feedback from the verification.
Okay.
Sir, we recently had a CAG audit, sir, wherein they conducted.
So that is a different thing. CAG audit and all those things are different. These are departmental.
Okay, so we'll consider your suggestion. Thank you.
Yeah, thank you very much. Thank you. Good, otherwise good. We are happy.
Thank you so much, sir.
Dr. Pika, very good presentation. In fact, I appreciate your efforts. You have indicated in your presentation about 4 Ds. Okay.
Yes,
so before intervention and after intervention, how do you track the delta improvement?
So we have data of RPSK only performing before the intervention, and what data right now is being provided is after the intervention.
So
that is where this integration is.
Delta improvement?
Sorry, sir?
Are you satisfied with the delta improvement?
We definitely have to improve further, sir, since it's been a short time and due to COVID, we had a lot of backlogs. But definitely there has been improvement compared to the earlier coverage, but down the lane, we will definitely look into more improvement.
Because you have to take out the SAM and MAM children out of the their pitiable situation, keeping in view that stunting and wasting is a major problem among children. So you have to track very carefully the improvement part.
Yes, sure, sir. We shall do it.
Thank you, please.
Thank you so much, sir. Any other suggestions?
Works under comes under Department of Health and Family Welfare. Since last 65 years, we are in existence. In 1957, from that time onwards, we have started implementing our Drugs and Cosmetic Act in the state of Karnataka. Sir, we have a strength of about 786 sanction strength, but presently we are working with 450 staff. And our main functions are like licensing of manufacturing licenses and establishment of licensing for establishment of sale of drugs, approval of drug testing laboratories, and monitoring of medical devices and cosmetic and quality of drugs. And we are also licensing the blood centers and blood storage centers. There are various challenges. During the pandemic, we faced a lot of challenges before implementation of our what all we wanted to do it, like manufacturing, like our routine work was licensing of manufacturing and sales. And during the COVID, and suddenly when the COVID pandemic situation started, we were facing a lot of difficulties in this. And distribution of COVID drugs, distribution of liquid medical oxygen, and at the district level, taluk level, and in the micro interior villages level, which was an Hercules task. Similarly, during that time, pandemic 1 and COVID 1 and COVID 2 situation, even the mask and sanitizers and COVID drugs were in real shortage, and there was a lot of demand. And we had severe challenges of communication and coordination among the departments like health and family welfare, drugs control, and we had severe shortage of human resources, and there were very budget restrictions also. We had about 26 time-bound services, actually 26 time-bound services in Sakala scheme. And this was time-bound services. And we had about, in last 1 year, from 1/4/21 to 22, we have total 12,418 applications were disposed. And out of which, after the government, when introduced Seva Sindhu 2, 16 services were covered, which were paperless, faceless, and contactless. Actually, during COVID, we were able to overcome these all problems because of technology and because of online services, faceless and contactless. So with COVID work also, we were able to give services to the public, to the manufacturers, to all the stakeholders at retail, wholesale level. And it was first of its kind in the country. Regarding ease of doing business, actually, we have done online application. The department has implemented the software that facilitates the submission of application online, payment of fees, a safe gateway, and monitoring of files online and without any physical interface. And final approvals are given. It is completely transparent, files, everything. The benefits, applications are given online and which can be tracked. SMS notification goes to the stakeholders, and at every stage, the processing of the applications can be viewed by them. Messages are going, and online payments and gateways are very safe. And the benefits of this is the applicant can view the application stage by stage, and the monitoring, even the MIS reports we are getting, and time to time we are monitoring the reports where all delays are there, and quick decision making process can be taken place. We have some of the distinct in our process uniqueness in our department. One of its kind is Jiva Sanjeevani, where we have created a portal where a citizen can access to the availability of the blood. Suppose he is in one remote village, he can access this website portal, and he can access which is the nearest blood bank where the blood is available, component, which category, A positive, B positive blood, he can easily access. The left side of my slide, it is the website where they can access. The right side is the blood bank's name, which blood bank, which place, which part of the Bangalore or which part of the Karnataka it is.
Sorry, sir, for interruption. Actually, your screen share has not been proper.
Okay. Now it is okay. Now it is.
Can you please exit your slideshow? Then only I think it will be better.
Exit out.
Yeah, now it's moving. Yes, sir.
Yes, sir. Okay.
Don't slide show it. You can show it like this.
Okay. And one more e-sampling has been implemented in department. That is e-sampling regarding whenever a drug inspector draw the sample to check the quality of drugs, the sample is drawn from a retailer, wholesaler, manufacturer level, and which will be sent to the lab through e-sampling. So as soon as a drug declared not of standard quality or is spurious, the message will be reflected to entire all the stakeholders like retailer, wholesalers at a stretch. So there are about 45,000 chemists. The message will go to the entire 45,000 chemists, and which will prevent the use of not of standard quality drugs. right side of the slide is the message which will go to the each stakeholder, and the left side is the sampling, our e-sampling. And with this, during the COVID times, we were able to track the spurious drugs, not of standard quality drugs like favipiravir, which we were sampled and which was declared not of standard quality. The investigation is still in progress. Like this, we were able to get the reports fast, and we were able to see that the quality drugs were supplied during pandemic also. Next. During the pandemic, the most problematic problem we faced was remdesivir injection, amphotericin, and liquid medical oxygen to the patient at right time. So we, under the leadership of a drug controller, we created a web portal with the help of Nick and with the help of officials, and created an indent-based, like on my left side of the slide, a portal was created where the hospital doctors were putting the indent for the requirement of remdesivir injection, amphotericin injection, which was verified by our officer. The right side of my slide will show you that image where the department officers, based on the SRF IDs and occupancy of the bed, we were collecting that details, and officers were allotting the remdesivir injection based on the occupancy and SRF IDs. So each hospital has to upload that. And once the officers have allotted the remdesivir injection, the message will go to the patient, which is one of the uniqueness. When a patient will get received, yes, there is 6 vials have been allotted to the patient during the COVID. This was a unique, and where all the patients were used to know that they have received this much of vials. In association with our department and health department, we coordinated, and during the COVID, there were patients who were purchasing paracetamol and COVID drugs without prescription. So we, along with the health department, we collected the data. All the officers in entire district started collecting the data regarding ILR and SARI, and those patient details were uploaded in the website. The left side of my slide, which shows that in that in that portal, they used to upload the details of the patients. Suppose about 100 patients might in a day, they would have taken the medicines that was uploaded in that, and through Aptamitra, a portal where we shared that data with the health and family welfare department of the state, where in the state level, district level, and at taluk level, micro interior level, how many patients have purchased ILR SARI drugs or COVID drugs, that data was shared with them, and we were able to do the traceability, that is triple T's, and for the further follow-up of the patient by the health department. Based on the challenges what we are facing, we adopted each process, were documented and were reported to the government time to time, and new portals were created to overcome the challenges. And with these new portals, we were able to give time-bound services and drugs availability. We made the availability of the drugs at rate fixed by the government. The responsibility of each and officer was fixed, and goals were fixed, and complete transparency was brought in the supply and distribution of COVID drugs and liquid medical oxygen. And with this, we were even monitoring the other essential drugs which were related to the COVID, like amphotericin and cocktail, which was a very famous drug during the COVID, which was used. And a lot of officers from the department were nominated as nodal officer, and their contact details were published in the newspaper to address the grievances of the public. One more most important is the department formed a vigilance squad under the chairmanship of our drug controller, and we have raided and monitored to see that the misuse, hoarding, and black marketing of remdesivir injection, amphotericin, and liquid medical oxygen during the pandemic. And during this time, we have booked 11 cases, criminal cases, of which 4 to 5 have already filed in the court, remaining are in the investigation. And with this, we have also followed up the price cross-check, and we have done assisted police also in other raids regarding liquid medical oxygen.
I would request you to conclude now, please.
Yeah, we have last one. We have made a war room, which was 24/7. All the officers were working. We are receiving thousands of calls per day, and we were able to make the availability of drugs and liquid medical oxygen based on the requirement. And we were taking all the calls. Each calls were recorded, and we were able to divert the supply wherever requirement was there. Even the industrial oxygen which was supplied, we stopped that and diverted to medical use. And officers were also deputed on the manufacturing unit of oxygen to see day-to-day supply of oxygen. And one most important is along with the Sonu Sood Foundation, a famous actor, where in one incident, the patient, the 20-30 patients were saved because there was a leakage of oxygen. Our officers coordinated then and plugged that leakage, and we were able to save that 30 patients, and we were able to provide the new line of oxygen to them. Approximately 10,11,043 vials of remdesivir injections was supplied. An average of 700 metric ton of liquid medical oxygen per day was distributed in Karnataka. Regarding my left side, day-to-day updation of remdesivir injection, and the second one is the distribution of oxygen from the manufacturer, how much we have collected, and the website where all the details were published on day-to-day basis. Thank you, sir.
Thank you very much, sir.
Thank you very much, sir.
Thank you very much. I think you have done very good work during COVID. But tell me, are you still continuing this process, this system?
Sir, yes, sir. So the portal system is, as of now, we have kept on standby. As and when again it started, the portals again will start working, sir. Now we are just visualizing the COVID drugs situation, like drugs requirement, any shortage is there or not. We are visualizing that, sir. As of now, we are under control. Thus, preparation, we are ready for any type of preparedness, sir.
And,
market survey is also being done.
And what is one lesson which you have learned while doing all this, no? That means if the COVID comes again, you will see that you don't repeat that mistake which you perhaps did that last time.
Yes, sir.
Yes, sir. Yes, sir. Definitely, sir.
So is there any pinpointed thing you wanted to do but you could not do?
Sir, actually, when the COVID started, we were not prepared. The technology, the use of technology, little bit, we took about 7 days, 10 days to develop that software. That was the time, that was the crucial time. We took about 7 to 10 days, sir. But once the system came in place, we were able to do a very good systematic distribution to entire state.
So
And it is,
should we assume that you had no oxygen shortage because most of the states reported oxygen issues, no?
No, sir. Yes, sir.
So I just wanted to know how was the situation in Karnataka with regard to oxygen supply?
Sir, with our we were about 450 metric tons were normally what we are getting from the manufacturers of Karnataka. What has happened is remaining, we got some assistance from the central government also regarding the oxygen, which was supplied to us. And we were able to do it on an equal distribution, sir, based on this indenting only. They used to give us the number of beds. This much beds are there. This much patients are there with the high performance liquid oxygen is required. So we used to supply based on that, sir. In between, we had little bit of constraint, but once we got the supply from Government of India, we were able to manage the supplies.
Adequate infrastructure is now Thank you.
Sir, an adequate infrastructure has been developed in all the taluk hospitals and district hospitals to take care of liquid medical oxygen.
Okay. Thank you.
Thank you, sir.
Thank you.
Sir, very good project. In fact, you have used technology to the maximum extent to facilitate patients during COVID time. My question is that during COVID second phase, particularly, the ventilators were supplied by central government, which were received from various countries as a help, but no training was given. So how did you manage the training part of using ventilators?
Sir, actually, that comes under our Department of Health and Family Welfare Commissioner. So our duty was just to see that the oxygen supplies was not affected. So we used to, as per their requirement, we used to get the supply done to these hospitals, government, private hospitals.
Sir, here it is the ventilators, whatever the ventilators provided now, it is taken by the Commissioner of Health, sir, Health and Family Welfare. They have taken the responsibility, they have distributed, and they are used the ventilators, sir.
Okay, thank you. And second issue is that you have
Yes, sir.
mentioned that medical devices is also in your area. So regarding ease of doing business, are you
Yes.
planning to set up some park for manufacturing of medical devices?
Yes, sir. Yes, yes, sir. Yes, sir. It is already we discussed with Honorable our Health Minister now. Sir is already assured to the stakeholders here that they are going to take up the issue in the Chikmagalur district or Mysore district, sir. It is under process, sir. We are taking into the Industry and Commerce Ministry, and we are discussing along with other departments on department and stakeholders, sir, to set up the pharma park, sir, especially for medical devices and manufacturing units, and as well as cosmetics, sir. Cosmetics also is one of the major industries, sir. And we are third in the country, sir. We are supplying equipments, also medical devices. We are supplying the entire country, and 10% of the branded drugs are manufactured in Karnataka. We are supplying entire India also, sir. Thank you very much, sir.
Thank you, please. In fact, you have to take a lead in making Atmanirbhar Bharat as far as medical devices is concerned, because this is a very crucial area. Unnecessarily, we should not import the huge costly equipment, and after that, there is hardly any maintenance for that. Thank you very much for your efforts.
Thank you, sir. Thank you.
ICDA. I'm going to represent a scheme known as Indira Gandhi Matritva Yojana, Poshan Yojana. It is the initiative of the government of Rajasthan. First of all, let me come up with the concept of e-governance. Basically, we have applied under the category of e-governance. What is e-governance? E-governance means a government working on the concept of ICT. And what is ICT? Information, technology, and communication. And what can be the best example other than the Indira Gandhi Matritva Poshan Yojana, which is being announced by the Honorable CM of Rajasthan in the budget announcement of 2021. Let me first introduce what is it. What is Indira Gandhi Matritva Poshan Yojana? It is a conditional direct benefit transfer scheme which gives cash benefit to the beneficiary's account directly, and the beneficiary is the second time pregnant and lactating mother. The benefit received under this scheme acts as a catalyst to ensure more and better nutrition for mothers. I'll come later for the different installments which are given to the beneficiary. Unlike other maternity benefit transfer scheme in India, it includes a social behavioral change communication component to encourage the utilization of direct benefit transfer for purchase of nutritious food and promote recommended pregnancy care and child care practices. The uniqueness of this scheme is that it is completely paperless scheme. The beneficiary does not come to the department, nor does we go to the beneficiary physically. All the data which has been taken, it is taken from the medical department portal, that is the CTS portal of the medical department. The second time pregnant ladies, the data is taken from their portal, and it is then as per the eligibility criteria designed in this scheme, different installments are given to the beneficiary when she conceives, when she is pregnant with her second child, and after the delivery also. There are almost 5 installments that are given to the beneficiaries. It represents a stellar mode of convergence across government departments for optimization and efficiency. Basically, it was based on the concept that Rajasthan is determined, like when we went on for the survey of NFHS 15-16, we saw that Rajasthan was lagging behind in low birth weight, wasting, stunting, and anemia. That is why Rajasthan wanted to improve the maternal and child nutritional indicators in Rajasthan. Therefore, we opted for this scheme. Secondly, Rajasthan stepped up to comply with the mandate of National Food Security Act. As we are all aware that the National Food Security Act of 2013 says that 6,000 rupees should be given to all the pregnant ladies. Government of India is already implementing a scheme from the central government in which the state government also has a share, that is known as Pradhan Mantri Matritva Yojana, in which 5,000 rupees is being given to the beneficiaries who are pregnant with their first child. In that scheme, basically the forms are being filled from the beneficiaries in the field, and then it is uploaded in the portal. Whereas in Indira Gandhi Matritva Poshan Yojana, no forms are being filled. This is the timeline showing basically the announcement was made in the year 2021. Then we developed the software for the whole process that was to be followed in order to transfer the amount to the beneficiary's account. From the amount was transferred in the account from the cutoff date which was taken was 1st November 2020. And then mapping was all done, because basically the functionaries which are involved in the field are Ashas and ANM. So the data which was with the ICDS department of the Anganwadi centers, we mapped the data of the Ashas and ANMs so that the data could be taken from the PCTS portal. The Anganwadi center was the main point, and the Asha who was working with that Anganwadi center, her code was also integrated so that in the PCTS portal of the government, the Asha's code is mapped there. Therefore, with the help of the Asha's code, the beneficiary of the Anganwadi could be drawn from the PCTS portal. It was a tough mechanism. We took a bit of time in developing the software and all the parameters for all the installments. And later, first payment was done in June 2021. And since then, payment is being done from the state level. In one click, all the beneficiaries whose installments have come for the financial sanction at the state level, in one go, the amount goes to all the beneficiaries from the bank directly into their bank account, which is linked to the Jan Aadhaar portal. Conditionalities and direct benefit of transfers. I was previously mentioning what are the criteria on the basis of which the payment is being paid. The first is after the first installment of rupees 1,000 is paid after the registration of pregnancy within 120 days of last menstrual period. Second installment of 1,000 is paid for 2 antenatal checkups within 6 months of the pregnancy. Third installment of 1,000 rupees is paid on the institutional delivery. Fourth installment is of 2,000 rupees is paid on the childbirth registration and first cycle of immunization within 105 days of the birth. And as you all know, we are facing with the problem of population. Therefore, the fifth installment is being given when the couple goes for the family planning mode. He goes for any family planning mode. The scheme outreach, over 24,000 women received direct benefit transfer. Till now, they have received over 87,000 households have been received interpersonal counseling. Basically, the ANMs and the Ashas and Anganwadi workers have also been trained in order to provide, give education on what is the benefit of nutrition in their life during this period of when the beneficiary is pregnant with the second child, and what kind of food should she eat in order to have a baby who's very healthy and is not underweight. More than 18,000 Anganwadi workers, Asha and ANM trained to provide counseling and mobilizes communities to improve nutrition.
Uh,
70% of the women are registered at Anganwadi centers, attended maternal and child health and nutrition day. 81% of them receive nutrition counseling. Actually, we on every month we have a
sorry for interruption, ma'am. Can you please conclude your presentation in 2 to 3 minutes?
Okay. Next. These are some of the posters in order to make people aware of this scheme that we have introduced in the field, and it is being provided to the beneficiaries through the Anganwadi workers. Expected outcome of SBCP exposure: increase cash spending on food. These are the habits that we are trying to improve in the beneficiary. Improve weight gain during pregnancy, improvement in dietary diversity, improved infant and young child feeding practices. Best practices: improving coverage of direct benefit transfer under the NFS Security Act, which provides us that we should give 6,000 rupees to all pregnant ladies. The government of India has recognized the need to extend the direct benefit transfer to second-time pregnant mothers and provide direct transfer benefits for second-time mothers if the child is female. Now the government of India has come up with a new scheme that in that scheme they are going to provide 6,000 to the second-time pregnant ladies who are delivering a female child. Incorporation of SPCC in DBT's indirect benefit scheme, because previously only the cash transfer was being given. We have included SBC activities also in this scheme. It is a completely paperless enrollment, as I explained previously also, and it is a great example of a convergence between three departments. Like the data is being taken from the medical department, ICDS department is providing the benefit to the beneficiaries, and the money is coming from the PMFT, that is the mining fund that has been deposited with the districts.
Please conclude now.
Thank you, sir. This is the end of our scheme. And this
good,
is
ma'am. I think good work, good initiative. But just one question I have in mind. If I heard you correctly, you said that the last installment for DBT is subject to his agreeing for family planning. Am I right?
Right, sir.
So I just want to know how many of them actually, in terms of percentage, you can tell me out of 87,000 or so number which you have shared, how many of them actually go for this last installment?
The percentage is very low. I agree to it. Basically, we've just started with this scheme, and we are campaigning in the field, and we are making people aware of it, and we are hoping for better results, sir.
Yeah, but I think you will have to do something inbuilt in that so that people really go for it. No, maybe right. You can give.
We have IC material we have developed on this. We are also through our SBC activities, we are also telling the people the benefit of having less children, and population control is the best for any government's economy.
The government keeps on telling, but they have other people who are forcing them to go for more and more children.
So this is the first step by the government in this direction. So
okay, good. Thank you very much.
Thank you, sir. I just wanted to add one more part which I forgot. Basically, through the mobile, the beneficiary, when they get the installment in their account, we give a message is being sent to them that you have received this installment in your account. And in some cases, because it is a bank linked account, bank account is linked to the Jan Aadhaar. If they are not fulfilling some criteria, the message goes on that also that this is lacking. So you get it done immediately so that you can receive your next installment.
Okay, thank you.
Thank you, sir.
Madam, what is the current level of IMR, MMR in your state, and what target do you have for next 5 years?
So I'm not aware of it right now.
Okay, because this is linked to your efforts of ICDS improving the nutrition of child as well as mother, definitely will lead to better outcome of IMR and MMR.
If we study both the data for NFHS 4 and NFHS 5, we have surely improved. But still, in Rajasthan, though we stand at a better position than India, but still there are miles to go. We need to improve the condition much more. Exact data, I'm not aware. I'm not sitting with the actual data. That is.
Okay. Thank you, please.
Thank you.